and Clair from CMS. And we're going to be talking about building for the CMS interoperability and patient access final rule. We'll be talking a little bit about the rule and then also what we're doing with working with industry and how to get involved. And with that, I will pass it off to Denise.
Thanks, Dave, and thank you all for joining today. I'm going to keep my piece really, really short because Dave's got all the super fun stuff that you actually want to see. But before we dive into actually implementing the final rule, we thought we'd do a quick recap of what the final rule requires. So if you go to the next slide, I will just very quickly give you a little context of where this fits in. So CMS is on a never-ending road to interoperability. This is not, there's no endpoint. We know technology is constantly changing, needs are constantly changing, and so we're working to be nimble with that and move us forward and really kind of focus our attention in three areas: patient access, connecting healthcare through data exchange, and focusing on technology and standards that will get us there and get us there together in an interoperable way. And clearly, the most important thing is that all of this is built on a foundation of privacy and security. And so that's where our head is at as we think about this first step on the road to interoperability through the Interoperability and Patient Access Final Rule, which was published to the Federal Register on May 1st. So on the next slide is something that you think you've actually probably seen already from a handful of folks this week. And that makes us super happy. We love that folks are using this slide. But this is a one-stop shop overview of the final rule. And I'm just going to focus on one specific piece today because that's the one I think that you are all most interested in, and that's the two application programming interface policies. But of course, we are always available, and I'm always available. So the one thing I want you to get out of this presentation is if you have a question, reach out. Happy to help. We're obviously super passionate about this stuff and always happy to answer questions. But the two application programming interface policies finalized in the rule are both applicable starting January 1, 2021. We did make a recent announcement when the rule was published in the Federal Register on May 1st. We noted that we would be enforcing 6 months of enforcement discretion or exercising 6 months of enforcement discretion, appreciating that the healthcare industry has a lot to deal with the current public health emergency, and so that provides people with a little bit more opportunity, and we won't be enforcing the policies until July 1, 2021. But starting in January 2021, we are requiring that payers impacted by this rule, who are specifically Medicare Advantage plans, Medicaid and CHIP fee-for-service, Medicaid and CHIP managed care, and qualified health plans on the individual federally facilitated exchanges, need to implement and develop a FHIR-based API to facilitate sending patients their data via an API to the third-party application of their choice that they can then access and use to be better informed decision makers and help coordinate the care and ultimately help improve care. And through this API, payers need to make available adjudicated claims, encounters with capitated providers. The claims and encounters include cost data. They need to make provider remittances and enrollee cost sharing data and clinical data in the form of the USCDI, the US Core Data for Interoperability version 1, available through the API. For Medicaid plans that also have prescription drug options, they also need to make claims for their drug available, and they also have formulary information they need to make available, and CHIP and Medicaid plans need to make preferred drug lists available. So that's all the information that has to be included in the Patient Access API. It needs to be available no later than 1 day after a claim is adjudicated or information is available to the plan. And we also have a number of other requirements around documentation that needs to be made available, when and where and how, the kinds of education that's necessary for patients, and then obviously the technical and content standards that need to be followed for the API itself, which of course what Dave's going to talk about will hit on some of that. And there are also some privacy options available, as privacy and security is a huge piece of this puzzle for all of us. So we did finalize an option for payers to be able to request a privacy policy attestation from the apps that are looking to facilitate patients using their data in a way that works best for them. So that's the Patient Access API. The second API is the Provider Directory API. And that is a publicly accessible API where the payers need to make their provider networks information available through a digital endpoint available on their website. So truly open API. This is public information. This is stuff that a lot of you already have out there, but putting it out in this way will make it possible for innovation and creative use of that data to best help patients. So that API needs to make available some basic information like provider names, addresses, phone numbers, and provider specialties. The required data are the floor, but we strongly support anybody who's willing to reach for the stars there, but that's the minimum basic information that needs to be available, and it has to be updated no later than 30 calendar days after information is updated or available. And this is for all the applicable plans that I mentioned, except for QHPs on the federally facilitated exchanges, as they already have a requirement in this area. So that is the basics of the policy for the two APIs, and I'm going to pass it over to Dave to get through the fun stuff. But just so you know, please never hesitate to ask questions, and we are here and happy to help, and thank you all for your support in this effort. So Dave, all you.
Great, and so here's how you can find out more information about the rule as well. And so we've also been working with industry at every step of this process. And so I'll be talking about a few things where we are working with industry for each of these items. But also I just wanted to call to please get involved. There's a number of calls that happen every week. And we'll be talking about a lot of these different things today in this presentation, but this is really a great opportunity to get involved and be part of the process. And then also to participate in the connectathons. So HL7 has 3 connectathons a year in January, May, and September. And then also CMS, Vinci, and CARIN Alliance also hold occasional connectathons. And we've heard, I think, earlier in this conference that Vinci and CARIN are planning potential connectathons in August. So there's some good opportunities to get involved and to get involved in the connectathons. So I wanted to talk about some of the priorities for industry engagement. A lot of these are associated with the topics that Denise just mentioned. So claims and encounters is one, plan coverage and medical formularies, provider and pharmacy directory, and then lab results and other health information, and we'll talk about each one of these. Claims and encounters, that's really run by the CARIN Alliance, and that's done with the Blue Button Framework and Common Payer Consumer Data Set, or CPCDS. And really this is a way for patients to get access to their claims information through an application of their choice. And so the idea is that, through that claims data, they can get a lot of information about their health, the type of coverage, the drugs that they're on, and the prescriptions, as well as the primary care treatment and cost. And so these are the folks, a large group of folks that announced support for CARIN Blue Button at the last August at the Blue Button conference. And so it's well represented. We also, there's a number of resources available. So there's an implementation guide that's currently an STU1 ballot. There's also some additional documentation that you can reference as well. And then also MITRE has been developing a reference implementation, which is all open source based on an Apache 2.0 license. And that includes a server, a client, and an authorization server in their GitHub repositories for each one of those. So I urge you to go and check those out. And with that, I will, my colleague Saul Kravitz has done a demo of the reference implementation, and I'll show that to you now.
This is a demonstration of our reference implementation for a CPCDS client and server. It includes a reference client that can connect up to any server that implements the Smart on FHIR authentication, a server that includes some explanation of benefits data for a number of patients and an authentication server. So we have it hardwired to connect up to our server. So I'm just going to connect up, which would allow the member to authenticate against their payer's data source with their credentials. And they're presented with a dashboard that shows their demographic information and a query interface that lets them select explanation of benefits by date range. And this will come back and show us the explanation of benefits that are available. And then once this list is provided, the member can drill down and see the details on a particular explanation of benefit. And that's what we have to show: authentication, selection by date range, and display of explanation of benefits.
So the next thing I want to try to cover is plan coverage and medical formularies. A medical formulary is basically a list of drugs that an insurer covers, and it's based upon the effectiveness of the drug, the safety of the drug, and the cost. And this really allows a member or a patient to get access to these costs, to see what drugs are covered, and to really help compare their drug costs across a variety of insurance plans. We have a number of folks that are involved in this effort as well. And there's really a couple of different use cases that we're sort of aiming for here. So one is you've got a health plan and you want to find out what the costs will be for your particular set of medications. And so there's some of this that, so on the left we have a mobile application. Some of this interaction happens outside of the scope of the FHIR implementation, the formulary implementation guide. Some of it is within. So what this mobile application could do is could get a list of the medications for that patient, and then through the formulary IG, they would be able to query the formulary service on each of those medications and get the coverage information specific to the plan that the patient is in, specific to the drugs that that patient is taking. The second use case is if you're shopping for plans. So either you don't have a plan or you're looking to change plans. And again, what you do is you're getting the list of the medications from the EHR system, and you are then sending those to each of the formulary services that are involved to see what the coverage is for each of those drugs that you are on, just so that you can compare plans across different plans and across different providers or different payers. So so this really, it's all tailored to your particular use of drugs and your particular situation. So there's an implementation guide for this. It has been published as an STU1 specification, or IG. There's hosted reference implementations, and I'm about to show you that now. So you can go and play with these on your own. So there's a client and a server that are on Logica Health. And then reference implementation guide code, which is all open source. It's Apache 2.0 license. So there's a server, there's a client, and then there's sample data that you can use as well. And then finally, there's touch scripts based on touch, which allows you to validate your reference implementation, your implementation as well as the reference implementations. And so with that, I'll just show a quick demo. So here's our formulary reference implementation. And so what I can do is I can select a coverage plan, say Healthy Blue HMO Gold, and I can look that up. And I can see that there's a variety of formulary drugs here. And this also indicates whether they're part of a step therapy, whereas, there's a series of drugs that often are tied to a particular condition. So in that case, it's a step therapy drug, whether it requires prior authorization, and whether there's a quantity limit. So for each of these, you can see what tier it's in, you can see what the copay is, the coinsurance, and so forth. So that's one thing you can do. The other thing that you can do is you can look at coverage plans. So you can look at a variety of the coverage plans. You can look Again, we can look at this one and you can see by drug tier and by pharmacy type what your copay and what your co-insurance would be as you go through each one of these. So, and it also indicates whether these are available through mail order. Lastly, what you can do is you can compare plans. So what you can do is you can go and say I can search for doxepin, and I can compare the plans across what you know, how they support this drug across a variety of different dosages. You can see whether there's quantity limit or a step therapy. You can see what the copay and co-insurance is across each of these plans. And so it really provides, I think, a good way for patients to see what their plan, what plan might work best for them. So so the next thing I want to talk about is provider and pharmacy directory. So this allows a patient or to find the providers and the organizations, the pharmacies that are most convenient for them, that are in their associated network, and really this is you know, helps to, you know, ease the burden on the patient so they can quickly find pharmacies and providers that are close to them. And there's a number of different use cases that you can use here. You can you can look up practitioners in a number of different ways. You can also do fairly complicated things like looking up specialists who accept my insurance and are affiliated with a local hospital, a practitioner near me who is accepting new patients, or for example, a female practitioner who speaks Spanish. So these are all things that you can potentially look up with this implementation guide. The number of participants as well for this. And there's, again, just like the others, there's an implementation guide. This is an ST1 ballot. There's a hosted reference implementation, which I'll show you in a minute, for both server and client. The reference implementation code is all available on GitHub. It's all open source with Apache 2 license. And there are test scripts as well, the Aegis test scripts to validate not only your implementation, but also the reference implementation. So I'll go in and show a demo again. So this is our provider directory. And so I can look up a provider. So I can go to the Acme Insurance of Connecticut, and I can type in a zip code and a radius. So I want to find folks within that 5-mile radius of that zip code, and say I want to look for ophthalmologists. So what I can do there is I can find these folks, and you can see that there are a number of them. This also reference implementation shows the query that actually is sent to the server as well, which is kind of a nice benefit. So these queries can get quite complex. The other thing that you can do is you can look up pharmacies. So I can look up, let's say, try Green Circle of Massachusetts. I'll go with and say I'm in Connecticut and I need to find a pharmacy. So I click find on this, and I will find, here is a list of pharmacies that are within the area. I can click on the pharmacy, see a map, and get more information about that pharmacy. And I can even go and see, get to directions via Google with that. So that's, again, something that I think that will really help patients to help find what they need to get the best, care that works well for them. Next, I want to talk about lab results and other health information. So this is based off of US Core R4. So this is US Core R4 based, the requirements for that have been based off of Argonaut pilot implementations, the ONC Common Clinical Data Set, as well as the ONC US Core Data for Interoperability, or otherwise known as USCDI. There are a number of open source reference implementations, so I can't possibly show them all today. And there is sample data through the ONC Inferno tool. That's an open source tool that you can use. There's a web API that you can use directly, and then also you can download the code and run it locally as well. And that allows you to customize it. It's all open source, all under Apache 2. So there's so those are the four that there's been a lot of priority on, but there are other areas for industry engagement as well. And so one of them is document requirements lookup service. The other is prior authorization support, and the third is payer coverage decision exchange. And we'll walk through those as well. So DRLS is really a way for providers to discover whether something, a medical procedure or a treatment plan requires prior authorization, and if so, what are the documentation requirements for that, so that they can get quick approval. So really the idea here is to do it at the time of service through an EHR system, and make it as convenient for the provider as possible. So the real focus here is to reduce provider burden, reduce improper payments and appeals, and really try to improve that provider to payer information exchange. There's really two components to the document requirement lookup service. There's the coverage requirements discovery, which it really defines the workflow for how a provider determines from a payer whether there are documentation requirements and whether something requires prior authorization. And so this helps, inform the clinicians to make the best decisions and meet the requirements of the patient's coverage. Then there's the second piece is documentation templates and payer rules. This allows you, the provider to find out what documentation needs to be provided so that the prior authorization can be successfully submitted the first time. Prior authorization support builds on top of DRLS, and so this provides the decision mechanism by the payer. So the provider submits the prior authorization request, the payer reviews it, and then sends back whether it has been approved or denied. And so right now, a lot of this stuff happens pretty manually through faxes and things like that. So we're trying to make it so that it's all electronic, so it's done directly through the EHR systems, so that the information and the approvals can come back much more quickly, which benefits both the provider and the patient. There's a number of people involved in this effort as well. And so I also have a demo for this, and this demo is done by my MITRE colleague, Ben Langley.
I'm going to give a demo of the CRD, DTR, and prior authorization reference implementations. This is the CRD request generator, which we are using to start the whole process. I'm going to be launching it as a standalone app running R4, and I'm running everything locally. I'm going to begin the process by hitting Patient Select to choose the patient and the device request. For Vlad Quinton, I'm going to select EO424 for home oxygen therapy. When I hit Submit, this will send the data to CRD and return a card. From here, I can launch the DTR Smart App and fill out the questionnaire by clicking Order Form. Because this is protected by the EHR, I'm going to have to log in and authenticate. The questionnaire now loads for home oxygen therapy, and you can see that information is pre-populated using CQL based on the information in the patient record. Since I'm not a doctor, I'm just going to fill in dummy data for all of this information so that we can move on to the next step and submit this for prior authorization. When I hit Next, it will prompt us to select which prior authorization endpoint to use. On the left, this is the raw data for the claim that's going to be sent for prior authorization. Right now, we have a few endpoints already supported. I'm going to send it to the Logica Health reference implementation. When I hit Submit, this will send the bundle on the left to this prior authorization server and will receive a disposition. As you can see here, we had an outcome of queued and a disposition of pending. Therefore, we're able to subscribe for updates. I'm going to come down here and select the type of subscription I want to test. Today I'm going to be using WebSocket. When I hit subscribe, you'll see that the WebSocket subscription was successful. Now, as soon as an updated disposition is available to the provider, it will automatically update this page with that new disposition. On the left-hand side, you can see the raw claim response, which just updated to granted.
So for prior authorization, there's a number of different implementation guides that are involved in that. That demonstration involves 6 different systems. So the prior authorization support has an implementation guide, which is an STU1 ballot. There is a hosted reference implementation, which you just saw. And then there's a reference implementation code, which is again open source and under Apache 2.0 license. And as well, we have a wide variety of Aegis Touchstones test scripts to validate the operation of that as well. Next, we have the coverage requirements discovery. That has an implementation guide, also an STU1 ballot. There's a hosted reference implementation for that as well, which you can try out and what you just saw as well. And then there is a reference implementation. The code for that is in GitHub repository with under the Apache 2.0 license. So again, open source. So all of this stuff is available. You can look at the codes, understand how it works, and integrate it into your own systems. There's also test scripts, again, to validate the behavior of the coverage requirements discovery. And then lastly, we have the document templates and payer rules. There's an implementation guide there, which is also an STU1 ballot. And we have a hosted reference implementation, which you saw. It's a Smart on FHIR app. And the code for that is also available on GitHub with an Apache 2.0 license. So all open source. So lastly, I want to talk about payer coverage decision exchange. And that is really the, when you move from when a patient moves from one insurance plan or company to another insurance company, this allows that patient to transfer the continuity of care information from one payer to another. And so this really helps to prevent medical errors and redundant procedures and really close some of the gaps that can really occur when you make some of these transitions. A lot of times things fall through the cracks. And so payer coordination is also essential to care continuity as well as provider coordination. And so, if a patient has home oxygen, they shouldn't be at risk of running out of oxygen when they move from one payer to another. And that's really what this is trying to solve. So there's a number of folks that are involved in this effort as well. And there is an implementation guide, which is an STU ballot. It is also, there is a hosted reference implementation, which you'll see a demo on in just a minute. And there's a reference implementation code in GitHub for both the server and the client. It's all open source, again, under Apache 2.0 license. And there are test scripts, Aegis Touchstones test scripts so that you can validate your implementation as well as the reference implementation. And so we have a demo for the PCDE, and this demo was done by my colleague Joseph Minieri and at MITRE, and so I will let him do his demo.
And basically what I'm going to be walking through is kind of a start to finish demonstration of PCDE, starting with member match and going all the way to actually retrieving the bundle or that PCDE coverage document. And I'll be interacting with my client as the new health plan, and Metals will be acting as the old health plan in the situation. So the person we're going to be looking for is named Robert Hill. And this is the information that presumably they provided for us when they came over to this health plan. So when I send this select member, what this is going to do is it's going to perform the member match operation against Metals. And as you can see, it successfully found the patient in their system. They provided a UMB to be used as the unique identifier to then send that task and be able to get all of the information. So that's kind of the first step in this process. Then the next step is actually sending the task to have the document generated. So here we need to provide the UMB that they had just returned. And we'll go ahead and send the task over. And as you can see, we got a response that the task was requested successfully, and it's provided with, given us this task ID to use, and this is the person. So now I'm going to kind of switch over to the to metals side of things and go ahead and send this task through. Okay. So as you can see, this is kind of from the old health plan's perspective now. And down here, this is the task that was just received. So we can review that. And we're gonna just go ahead and select all of these care plans to send over. All right, so the task was successfully submitted. So back on the new health plan side of things, we can take this task ID and go ahead and check the status of that here. So now the task is updated, status is completed, and it's for this patient. And this here's the where we can go get the full coverage transition document. So then the last step in this process is going from this, which is just going to be getting the bundle. And as you can see, it successfully retrieved that bundle with all the coverage information. So it's kind of the full process from start to finish of the member match, task, and then actually getting the bundle.
All right. So that completes, I think, the demonstrations and the talks over the individual pieces. But again, I want to reiterate to get involved. There are a number of calls that happen every week from the CARIN Alliance and Da Vinci on each of these items. If any of these are interesting to you, please participate and because I think the more participation we get, the better our implementation guides are, and it's great to have all that input. And then finally, to participate in the connectathons. As I mentioned, there are the HL7 connectathons are January, May, and September. We have one coming up September 9th through 11th. It's a virtual connectathon. So lots of tracks, I'm sure, that will occur, and lots of planning going on to put those things together. So this is a great time to be involved in that. And then also CMS, Da Vinci, and CARIN Alliance will be also holding the occasional connectathon. As I mentioned earlier, Da Vinci and CARIN Alliance are looking to have something in place by in August. So with that, I thank you very much for your attendance and attention, and open it up for questions.
We have 4 questions and answers in the session Q&A. The first one is someone who is asking that she works for a payer building a provider directory. And the question is, are provider languages spoken and electronic communications like the website or URLs or emails part of the provider directory requirement?
I can answer from the requirement side. They are not part of the minimum required data. So the minimum required data for the provider directory is only the provider names, addresses, phone numbers, and specialties. So those are the data that are absolutely required to be compliant with the rules. Now, of course, as I said, that's the floor, that's the minimum. So I'll let Dave speak to what's available in the implementation guide.
I couldn't find it in the implementation guide, but maybe it will be there. The other question is, I work for a provider. We send 8AT to our regional exchange. They have built interfaces with many downstream providers across our community and is able to determine who to notify. Will that be acceptable?
Who to notify and what respect, I guess.
I think to notify ADTs.
Okay.
This may be a question referring to the patient event notification policy in the CMS Interoperability and Patient Access Final Rule. There is a requirement for hospitals, including psychiatric and clinical or critical access hospitals, to send patient event notifications at the time of admission, discharge, and transfer. And that policy does not require API technology. It does. It is applicable only to those hospitals that already have the EHR technology in place to be able to send such messaging. And there is some detailed guidance in the rule about what sort of responsibilities are around identifying who to send that to, and the parameters around due diligence to try to get that information to the right place at the right time. If that's what the question is about, feel free to reach out and get you some more information. I'm not sure if that's if we're hitting your question on the head, but that might be what that's referencing.
The last question is about that CRD and DTR supports a number of possible different workflows, different hooks, external apps, and EHRs. Which workflows are currently planned to be supported by CMS DRLs? That's the question.
Yeah, so I think, you saw some of it. There's, certainly, and I think I've got a variety of additional information here, but really, the way that this is envisioned at the moment is using CDS hooks during the coverage requirements discovery, and for the document templates and coverage rules using CQL, the clinical quality language, and questionnaires. And then using X12, 275s, and 278s to exchange the prior authorization information. And so there's mapping, there's a mapping layer, a transformation layer that goes back and forth between these. And so, that's, in the reference implementation, that's kind of what we've included.
And I think that's it, and we are out of time.
All right, well, thank you very much. Appreciate it.
Thank you.
Thank you very much, David and Denise.
Thank you. Have a great show.